Once again, welcome everyone to our bi-weekly sessions. The chat is open for you to put in your comments, suggestions, diagnosis, differentials. We have 6 cases today, and without further ado, we'll start off with our first case. To again thank all the contributors for sending their cases, and the panelists and attendees for joining us. So this is our first case, and I'll take it over to Dr. Vivek.
Yeah, can you hear me?
Yeah.
Okay. So this is a 3-year-old boy who has had stroke. So he was well till 3 months back, and he just had a brief few days of left leg TIA, which resolved. So family didn't give much notice to it. And a month later, he had a dense hemiparesis on the left side, acute stroke. At the time was noted to have severe anemia as well, transfused. And he recovered nearly to his pre-morbid state. So maybe 80 to 90% recovery over the next few weeks with physiotherapy. He was not given aspirin at the time. Not sure what the thought process was. So different hospital. He was not given IV steroids. He was given oral methylprednisolone for a few weeks. So those MRI images, I just took some photographs. So Nihaal, you did get them, right? Yeah.
Yeah.
So maybe I'll complete the history first.
Okay.
And
yeah,
then
sure.
So then he was improving over the next few weeks. And then before he came to us, 3 days before admission to us, he had sudden onset obtundation. And this time he had, instead of right-sided hemiparesis and left bursive gaze. And low GCS, we were contemplating intubation, which in the end we didn't do. And G fed left side dystonic posturing, right hemiparesis. So he was in bad state. And his hemoglobin this time had been 8. The initial workup which you do, echo, homocysteine, cycling, it was all normal. And there was no preceding febrile illness or chicken pox in any of these 3 events. So the question was, what could be the etiology for his episode? Yeah, for his changes.
So I have 2 sets of MRI. I think this was 1 month prior to the present date. So on top, we have the diffusion sequences, and you can appreciate there are multifocal areas of cytotoxic edema, infarct in the right hemisphere, frontal lobes, parietal lobes, the subcortical, cortical regions out there, the periventricular region, the posterior periventricular region out there, and also the subinsular or the insular cortex and the temporal lobe demonstrating these changes of restricted diffusion or acute ischemic abnormalities. If you see on the flare, we can appreciate the edematous change on the right side, but there are also some white matter changes, some subcortical cortical abnormalities, which did not show restricted diffusion, suggestive of a chronic ischemic change or at least a late subacute ischemic change out there. Even if you see in the frontal lobe or there is subcortical region and the cortical region, it is hyperintense without diffusion abnormalities. So there are at least 2 different stages of ischemia. The ones on the right side are more acute or early subacute, demonstrating diffusion changes, and the one on the left are more in the chronic stage. I think a post-contrast was done. There is glial enhancement along the frontal lobes, the parietal lobes, the areas predominantly affected by the acute ischemic changes. This is common for an vascular event. So yeah, the initial scan, we have ischemia on the right side, more in the acute stage, and the left side has more chronic ischemic abnormalities. I don't think we have an MR angiography for the first scan.
No, MR angio was not done. Okay. So this is a month back, and this is now, like this admission after 4 weeks, 3 to 4 weeks of this second episode.
Second episode, now you can see that there's progression, especially on the left side, extensive infarct in one is left cerebral hemisphere, almost the entire internal carotid artery territory, the MCAs, these watershed territories. There are again new changes on the right hemisphere, the right frontal lobes, the superior temporal parietal lobe. So bilateral ischemic changes, extensive ischemic changes, and you can see that there are some areas of chronic ischemia, volume loss on the right hemisphere. There's mild ventricular dilatation because of the chronic ischemic changes with some degree of volume loss. But yeah, there is progression, new ischemic changes, extensive ischemic changes on both sides now. And then you have angio sequence on top. And on the angio, you can see that there is some collateral formation, at least the lenticosternal arteries are slightly prominent. Coming to the basal systems, you can see that there are prominent tortuous vessels out there. Even going up to the basifrontal regions, you can see that there's some tortuosity also along the ambient systems. So there is some tortuosity of the intracranial arteries. If you see the signals on the carotid arteries, the right carotid artery is significantly narrowed in comparison to the left. I think a vessel wall imaging was done. The contrast vessel wall imaging demonstrates there's some degree of enhancement of the bilateral ICA, the right more than the left. You can see that there is some degree of enhancement more on the right side in comparison to the left side. Middle cerebral artery is not that significantly affected in comparison to the ICAs. The MIP images demonstrate against stenosis or narrowing of the proximal distal internal carotid arteries. We do not appreciate the middle cerebral arteries, anterior cerebral arteries, but the source images reveal that there is some flow. The MIP usually overcalls it. So there is flow, but there is significant narrowing at the areas of circumfluous with some degree of vessel wall enhancement, especially on the right ICA. The FWI sequences, again, altered perfusion abnormalities demonstrated with venous stasis. You can see that the sulcal and the subcortical cortical veins are prominent, demonstrating that there is some perfusion abnormality going out there. We typically call this as the brush sign of the, especially see in Moyamoya diseases. So yeah, these are the abnormalities on the SWI sequences. This is a non-contrast T1 on the axials. And you can see that there is some cortical lamina necrosis, especially involving the frontal, parietal, and temporooccipital lobes on the right side. Then the question was, I think Dr. Vivek is trying to understand if this is a Moyamoya disease or Moyamoya syndrome. Is it a vasculopathy or vasculitis? So this was a paper which tried to evaluate the vessel wall imaging in cases of isolated Moyamoya disease without any syndromic associations. And what they found was on vessel wall imaging, the Moyamoya disease, the typical ones without syndromic associations, usually does not demonstrate any vascular enhancement. Whereas this was in the adult population, the atherosclerotic has eccentric enhancement of the vessel wall, whereas the vasculitic pattern has more concentric enhancement of the vessel wall. And these are the possible associated abnormalities which can be seen in Moyamoya arteriopathy, given that this child also has different stages of infarct and also collateral formation. And then I found few papers demonstrating the association of iron deficiency anemia. I think this is from the New Delhi group. I can see Dr. Suhasini and Dr. Atin Kumar with a patient of Moyamoya syndrome with iron deficiency anemia, and this is from Australia. And they also have had a case of Moyamoya syndrome with iron deficiency anemia. The only thing is for the clinical side, iron deficiency anemia is not very uncommon in India. So is it a coincidental finding or is it part of the megalonopathies such as sickle cells, which are commonly seen in Moyamoya syndromes at least? So yeah, this is the case, and I'll open the case for the panelists. And
So for me, if a child hasn't had post-minor head injury stroke below 3 years, because that's the most common cause, right? The child falls and has a stroke. And he comes with this type of presentation who is involving into Moyamoya. Majority of them have had severe anemia, 5 or below. So I just feel that severe anemia in Indian children is an important cause of Moyamoya.
Yeah. So this is I think this is, we have already collateral formation. So it's a Moyamoya syndrome with some vascular enhancement, vessel wall enhancement.
And that was also interesting that there was, we always say, oh, wall imaging, enhancement, vasculitis, but often, sometimes, as you have shown, Moyamoya can have wall imaging, wall enhancement, vessel wall enhancement. So doesn't always help.
Yeah. I think once we see the collaterals, I think that should be more suggestive, but yeah. So the syndromes can have wall enhancement, but only the disease may not have wall enhancement as demonstrated over there.
The other thing was that on the right side, the ICA is completely collapsed after the terminal portion. Is that right? On the right side? Sort of, there isn't any, on the right side, you cannot, NCA is not visualized at all.
No, that is, I think that if you have seen the MIP images, it overcalls it. But if you see the source images here, you can see the ICA, the flow of the ICA, the MCA also. It is reduced compared to the left side, but it is there.
So it's a gradual narrowing, right?
Yeah, narrowing. There is
complete. Yeah. So which again favors a vasculopathic
progressive
process, is it? Rather than a vasculitis, because there you will have some degree of stenosis, bleeding, and then, is that right?
Yeah, it's a progressive vasculopathy, Dr. Vivek, because in the initial scan itself, we have chronic changes on the left side, which I think may or may not have been picked up clinically, or a child may not have presented. But again, itself, the first image itself, we have two sets of different stages of ischemia. I think maybe an angio that time would have demonstrated some abnormalities. But again, the progression, as you can see over here with these collaterals, I would suggest consider Moya-Moya syndrome.
And
or association
what
with
stage of stroke does luxury perfusion come? So if somebody sees luxury perfusion, how old is the?
It's within a week, maximum 2 weeks.
Maximum 2 weeks.
Yeah.
And for us, learning was that aspirin was so important. It got missed, and he had another major stroke on the other side. I'm not sure if we would have prevented it, but what we could do, the basics. We were more into steroids. Methylprednisolone tablet, but aspirin was missing. Even though the interesting thing was when we gave him aspirin, he developed hematuria. So we gave him aspirin, he had hematuria next day. 2 days later, we tried again, he had hematuria again. So this is something which I hadn't seen before. So we were stuck what to give. So we gave clopidogrel, which did help. So it hasn't caused side effects, sorry.
For my learning, Dr. Vivek, I have not understood the association with anemia. Maybe I was not attentive enough. Or are you saying the patients you have seen with Moya-Moya and anemia were infants, in fact?
Yeah, so less than 5. If I see Moya-Moya above 5, I haven't seen that many anemic patients. If I see it below 5, I would say nearly all have had significant anemia. Now, I don't know the reason why that develops. People use this posh term rheology of the blood changes, which I don't understand much. So I don't know what it means and how does it cause it, but that's the observation.
It's just an observation. You don't mean it's causal. It's just an observation.
Yeah, so I cannot logically explain.
Because most patients, at least in Europe, when they present with Moya-Moya, they have no anemia. But there may be a different genetic background. There is increasing evidence that genetic factors play a role.
So the causes of monogenic stroke. So the monogenic stroke, we have few well-defined changes, vascular changes, and few of them, things like DADA2, ACTA. So DADA2 will cause stenosis with the, so it was not fitting into the known genetic causes, but there must be more. There must be more which we don't know.
Yeah, as put in chat, RNF213, by Dr. Sridhar, one of the causes of early onset Moya-Moya. So, Dr. Vic, are you going to send it for genetics, or consider that iron deficiency is
Yeah, the genetics, yes, but they don't have the money, so they cannot afford. So we're stuck there. Is there any role if people have experience of now doing heroic procedure like treatment for Moya-Moya, EDAS, will it help him? So if people have experienced bilateral damage already, because you do see the situation, so family wants to know how to treat. So anything, will EDAS work now if it is Moya-Moya? Will it help the child? That was something else which obviously we couldn't decide on, like what to offer them.
As you have seen, at least in these two sets, I think it could help. Because at least I think 3 ischemic changes are documented, if I'm not mistaken, within at least within a 6 months period. So there's chance of recurrence. I think EDAMS might be
already, this is the problem. Child is significantly affected. And it will prevent, but is the brain both sides is already so affected. What is left to prevent? That's the thing. What's left to prevent? So if somebody has if somebody comes after that second episode, he would do it. Now here is both sides. Just food for thought. That's it, because you don't know, because a family which cannot afford much and such big procedures, are they worth it, or you just just say no, there's not much one can do.
I think maybe an intervention or a neurosurgeon might be able to.
Right.
Yeah. The basal ganglia thalami is at least spared over here. If that is the region to be saved, frontal lobes. Brainstem cerebellum too. So yeah, I think the collateralization is still at around the stage 2. It has not significantly increased, but I think stage 2 and 3 they usually do EDAMS procedure. But yeah, to consider also the affected brain.
Right.
Yeah. All right. Yeah. Next case, Dr. Reid.
So this is a child where I learned from my overconfidence. So overconfidence creeps in sometimes when you see a very common presentation of few illnesses. So this child came 6 weeks back with acute onset leg pain, urinary retention, constipation, loss of ambulation, and wrist reflexes. He had pain around his perianal area, and there was loss of sensation till T10. And clinically, I thought, okay, he has got ascending myelitis. We did a MRI spine, and it showed significant edema till T6. And I didn't. So sometimes you just want to look at what you think, and we thought, okay, this is transverse myelitis, ascending myelitis, sorry, and gave IV methylpred, oral steroid few weeks, and the child completely recovered in few weeks. So this is like bread and butter for pediatric neurologists. And I think, okay, you're done with this. And I told them he's not going to have it again. And then 6 weeks later, he has pain around his chest, arm, and leg. And that was really non-organic pain, but I still did his MRI after 6 weeks. And by that time, the edema had resolved and the lesion could be seen in the cauda equina, which was there in the first one. I didn't see it because my eyes were not looking for it. So it's just a MRI, interesting MRI to see. Yeah.
So I think you just sent me a few images of the initial scan.
Yeah.
Yeah, I don't have a contrast, but you can see that there is abnormality over there in the lower lumbar cord, the cauda equina region, the focal lesion out there.
I sent you a second MRI. Oh, follow-up.
Yeah, the second MRI I have. Yeah, that I have.
Yeah.
So yeah, the initial MRI, I think these are the changes. I think it should not have been missed if the radiological,
Yeah.
I mean, the report hasn't mentioned that.
And
But
I missed it also. I was looking at the edema and I didn't see it. I can see it now.
Okay.
So I was looking at that edema. Yeah.
Yeah, I can see that. Yeah. All right. Then 6 weeks later, no abnormality in the cervical thoracic cord, but again, you can see that abnormality over there. Just T2 hypointense, predominantly hypointense with some central hyperintensities, which also corresponds with the T1 changes here. Centrally T1 hyperintense, again, T1 hypointensities along the periphery of the lesion. Axial images, you can appreciate that the lesion has the predominant change of T2 hypointensity, suggests to some degree of possible hemosiderin deposition out there. So a focal lesion with predominant likely hemosiderin changes was the finding. I think brain did not demonstrate any abnormalities in terms of vascular lesions or focal lesions, some degree of volume reduction, but other than that, nothing much. And then based on that lesion, we think of a possibility of a cavernous angioma. You can see examples out here which look similar to our case. T1 hyperintensity, T2 hypointensity. Post-surgically, it looks like this. And yeah, again, another example which looks pretty identical to our case with hemosiderin staining around the periphery of the lesion. So cavernomas would be the likely possibility for this child. There's no, I think the only other alternative is the myxopapillary ependymoma, but they're usually more extensive. So I would probably consider cavernoma as the first possibility. And I'll open the case if anyone has similar experiences with these imaging features or clinical appearance.
Yeah, it will be useful to know, especially now the question is whether one should operate because child is normal, or what is the risk of rebleed every year. And a learning still that in any form of edema, steroid does work. So symptoms have resolved.
So at least this paper, there's another paper in 2008 which has resected all the cavernomas.
Okay.
So the main the main treatment was resection. But what stage? I think it is better, as it's still a small lesion, so maybe should be easier than when it's there's bleeding or rebleeding out there. So I think with the surgical opinion, I think resection is the prime treatment for these cases. Though I think a contrast wasn't done. I think Dr. Vivek for your first case. Yeah. No, I think contrast wasn't done, so it's only a plain scan. But yeah, resection was the treatment of choice for all the cases with cavernoma. Yeah. So if anyone has similar experiences with cavernomas and they have resected them or given any medications to reduce them, the case is open. Talking about the first scan, I think contrast again wasn't given, right?
Yeah, contrast actually. Yeah, I did mention it, but people were doing it second time. This is not done from that was primary they came with.
Yeah.
They felt that this is a
no, just because thinking is ascending nerve root involvement if they had additional findings of cardiac and nerve root enhancement, but I don't think it was done.
Yeah.
So at least in literature, resection is the final treatment of choice. So yeah. And pediatric is less common compared to adults. I think I found only 14 or 15 cases from this paper. Yeah. So this has 10, another paper at 14 cases. So more common in adults, but yeah, to be kept in mind. If you see edema and these focal abnormalities with at least on the T2 sequences, it's helpful to identify these lesions. All right. If there are no comments, yeah.
Dr. Nihaal, I just wanted to ask one question. Like, if you can just zoom that image and tell us, like, what were the features which were going against, myelitis?
So myelitis, it will be T2 hyperintense. Edema will be T2 hyperintense. This is T2 hypointense. The SAG image on top. Again, this is the T1 hyperintensity suggests to have some degree of hemophilia or hemorrhage out there, which is again not seen in myelitis. Axial images, again, better. The zoomed in images, you can see that these hypointense dots out there. Myelitis will be T2 hyperintense because of the edema and inflammation, whereas in these lesions, that is hemocyte-rich lesions, you can see it's T2 hypointense. So it's an opposite finding of myelitis. And there is no cord edema, at least on the follow-up scan, but the initial scan also, there is some edema, but you can see there's a focal lesion out there, which should not be there on myelitis.
Sure. Thank you.
Yeah. All right. To our next guest, Dr. Sarvani, if you're there.
Yeah, hi. Right. Yeah, Nihaal, so this is actually this is an MRI, interesting MRI. The 6-year-old girl, she had global delay. So she had achieved ambulation by around 3 years and some meaningful speech, but now she was regressing. She had become non-verbal. She was drooling. She was having some behavioral issues. She's difficult to manage. She's the only child and born to non-consanguineous parents. No seizures, no hospitalization, so nothing acute in neonatal or later period to suggest the regression, explain the regression. And she's the only child. So there was this delay followed by regression, and now she has behavioral issues. Nothing else. Our blood parameters had shown deviant LFTs. I mean, they are twice the normal and slightly high ammonia. So on examination, she has this coarse, a little bit, I mean, I won't say coarse, she's looking a little dysmorphic and she is ambulant. So tone is normal, no mild hepatomegaly. Reflexes are fine. So there's this child with delay, regression, mild hepatopathy, some amount of dysmorphism. If we can take a look at her MR, because clinically there was no clear-cut markers towards what kind of a disease should I think of.
So MR at the age of 6 years, you can see that there is primary it's predominantly it is delayed myelination, but it's a hypomyelinating pattern. If you see the corresponding T1 images, the T1, the myelin signal is normal, whereas the T2, it is hyperintense, which is abnormal. So it is that most suggestive of a hypomyelinating kind of a disorder. The deep gray nuclei, if you observe the globus pallidi, again is abnormality to hypointense, abnormal for the age. Coming down to the posterior fossa, you can see that there is some degree of vermin atrophy. The anterior and posterior lobes are there. The hypointense globus pallidi corresponding changes on the SWS sequences, you can see again low signals on the SWS sequences. Also the brainstem structures, the midbrain, the red nuclei, the cerebral peduncle, French and nigra demonstrate low signals on the SWS sequences. Sagittal image again better demonstrates the atrophy, the anterior and the posterior lobes, and also there's some degree of finding of the fissures. Given these images, these are the differentials for myelin abnormalities with deep gray nuclear abnormalities. If there is hypointense T2 signals with hyperintense T1 signals, think of leukocytosis, especially involving the globus pallidus. Other findings can be gangliosidosis, but they usually have these lossal striatal abnormalities. Cocaine syndrome usually have focal mineralization. ODD again has these big globus pallidus abnormalities with myelination changes, and Krabbe's disease can sometimes have thalamic abnormalities, whereas our case does not have that. Differentials for cerebral atrophy with hypomyelination, again, these are the differentials. But any genetic disorder in the chronic stage or later stages can have some degree of volume loss in the cerebral and cerebral hemispheres. Solas disease, HAPC, 4H leukodystrophies, and covalent pathway disorders can have hypomyelination with cerebral atrophy. But none of these have globus pallidus changes other than 4H leukodystrophies, but they additionally have abnormalities in the posterior limb of internal capsules, the ventral thalami, and also in the posterior fossa structures. Then this is the a very commonly used algorithm for hypomyelinating disorders, been published in 2009. If there is hypomyelination with especially predominant changes of T2 hypointensity of the globus pallidus, think of leukocytosis. They can have additional abnormalities in the thalami and the brainstem, but initial changes are in the globus pallidus, and the rest of the algorithms or the images do not match our case. So thinking of leukocytosis, Dr. Sarvani, I think we have. This is a paper again. I think Dr. Mankad is part of the Pratik also from Canada. Very useful paper for hypomyelination, and again, different abnormalities, pattern recognition approach for hypomyelinating disorders. So in genetics, Dr. Sarvani.
So the interesting part here was they came to me with all of this, and in spite of the genetics, they were told that there is no diagnosis. So the fact is that the diagnosis in the genetics, it has been given a VUS, but it is fucocytosis and it's in homozygous. The mutation is homozygous and it's fucocytosis type 1. But since it was given VUS, they came with interestingly, they came that there is no diagnosis in this child. But yes, as the chat tells us that many people are already aware that this is the MR imaging favors fucocytosis, and the clinical markers, the coarse mild dysmorphism and the hepatopathy favors it too. So that's just an interesting MRI.
They usually also have some skin changes later on. Is that right, Dr.?
Yeah, so some kind of angiokeratoma.
Yeah, angiokeratomas.
Yeah, right.
Can I comment? I think the MR is very suggestive of fucosidosis, as we have seen, and in the algorithm. And as we have seen in the meantime, I wanted to ask whether you found any skin changes, because at the age of 6 years, you would expect some angiokeratoma corporis. And if you have no access or no easy access to genetics, as in many parts of the world, as a screening, you could look for vacuolated lymphocytes. This is not diagnostic, but this is an easy, cheap investigation. And I know that you don't have easy access to metabolic screening, but fucosidosis goes along with increased oligosaccharides in the urine. So oligosaccharide screening would show up for fucosidosis.
Right. So those are nice indirect markers. Thank you for your inputs that urine oligosaccharides and vacuolated lymphocytes would be indirect markers and surrogate markers. Yes.
So I think the imaging and clinical phenotype matches. So yeah, Dr. Sarwani, you can.
Yes,
Yeah.
that's right. So
Yeah.
It does match. So yes, and
Yeah.
in spite of the fact that it's reported VUS, it is
Yes.
fucocytosis.
Yeah. Yeah.
Thank you so much.
Thank you. Thank you. All right. Next case, Prituja or Shawnee, if you're there.
Yes. Good evening, everyone. We had an 11 years old male child who was born out of non-consanguineous marriage with no birth history, developmentally normal child. And he was diagnosed to have double indent left ventricle on third day of life. So he started complaining with left ear pain. This was after the swimming session that he had, which subsided with medications. Followed by that, he had fever and headache with occasional vomiting. With this history, he presented to us, and the history lasted for around 10 days. There was no other history significantly, no history of exposure to any pets. So since there was history of ear pain, fever, headache, vomiting, and CT scan that was done outside shows some hypodense lesions. So we went forward and did the MRI.
All right. So we have two sets of MRI, 1 week apart.
Yes.
So once we can go to the labs after the MRI, Prituja. So okay, we have diffusion scans on over here, and you can see there are multi focal abnormalities demonstrating restricted diffusion in the bilateral hemispheres. More along the inferior aspect, you can see that the frontal lobes, the basal ganglia on the right side, bilateral basal ganglia, the temporal lobes out there, and also there is some degree of debris or ventriculitis in the frontal horn, the left atrial ventricle, also in the third ventricle out there, and the fourth ventricle. So multifocal abnormalities, small and ventricular abnormalities on the diffusion sequences, mild degree of ventricular enlargement out there. On the T2 various sequences, you can appreciate these focal abnormalities with some central areas of T2 hyperintensity is more predominant in central areas, whereas there is hypointensity on the T2 sequences and intermediate signal within these regions. So again, they have minimal, some degree of perilesional edema, and yeah, the ventricles have some degree of grayish appearance, suggest of some exudates of the debris within the ventricles. On the T1 weighted non-contrast images, the central areas are hypointense. The peripheral regions are slightly hyperintense. Possibly the capsular regions that demonstrate these T1 hyperintensities. Some degree of volume loss in the cerebral and cerebral hemispheres. On the SWA sequences, you have this rim of blooming on the outside. Some degree of the inner aspect has some degree of hyperintensity. Possibly term this as a dual rim sign. So yeah, these lesions demonstrate peripheral hemosiderin deposition, and given that the child had ear infection, there is some degree of acute or subacute inflammation in the mastoid cells. You can see the diffusion changes in the bilateral mastoid cells, and on post-contrast, the paranasal sinuses also demonstrate some degree of enhancement. Post-contrast sequences demonstrate again all the lesions demonstrate peripheral enhancement, ring enhancement. Some internal projections were there, especially in the lesions, in the central regions of the brain. You can see also in the temporal out here, you can see some internal projections, but it is more or less a smooth capsular peripheral enhancement out there with some degree of ventriculitis. You can see the frontal horn enhances the ependymal margins. The third ventricle also, the lining of third ventricle enhancement shows enhancement. Cisterns were relatively free in terms of enhancement or exudate, but multiple peripheral enhancing lesions, ventriculitis, were the main features with mild degree of lateral ventricular prominence. A week later, we'll go back to the medications and the labs after these images. So a week later, again, the lesions are still present. Some of the lesions did not demonstrate distributed diffusion. Some had T2 shine through. I didn't put the ADC sequences. T2, again, there is some progression of the atrophic changes, but again, the lesions demonstrated similar size, similar in number. No new lesions were present. On post-contrast, the thing to note was the ventriculitis had reduced on medication. You can see that the frontal horn only a residual area of ependymal enhancement out there. The third ventricle also did not demonstrate a significant resolution of enhancement. But again, peripheral enhancing foci lesions in the bilateral cerebral hemispheres. We did a single voxel spectroscopy. It had a lipid lactate peak out there. But other than that, I could not appreciate any significant findings on the spectroscopy. As I think the chat has put in tuberculomas, fungal lesions, yeah, toxoplasmosis, all right. This is just to, okay. Let me see if I have the labs before we go to the discussion. Yeah, Prithija. So these are the labs done after the first and second scan.
Yeah. So initial blood reports were like hemoglobin was 13 with elevated WBC count, predominant neutrophils, and CRP was elevated 230. So CSF analysis was done, which is showing elevated count 6,575 with 85% neutrophils and lymphocytes being 51%. Protein is elevated 281 and sugars are 20. CSF gram stain is negative, no organism or no yeast grown. Culture is sterile. CSF bacterial PCR is negative. Viral and fungal PCR also negative. For tuberculosis workup, we have done a CSF gene expert, which is negative, AFB stain negative. Along with that, MAN2 was done, which is negative. And for toxoplasma workup, CSF toxoplasmosis PCR is negative and serum toxoplasma IgM is negative. And CSF cryptococcal antigen is also negative.
So
And
everything, yeah, sorry.
2D echo was done, same double inlet left ventricle, no vegetations were there.
Okay, so we don't have an answer on the labs. So I'll open the case. We're thinking of the same differentials which were put in the chat, TB, pyogenic, fungal. But I was favoring more of a pyogenic lesion and then a fungal abnormality rather than TB. So yeah, I'll open the case for that on the chat or the panelists to comment. And especially ventriculitis, I'm not being common. I thought bacteria are more common causes of ventriculitis rather than fungal and TB, but anything can happen. So yeah. The only thing to point out, TB abscesses at presentation, at least they're usually larger than the ones which you have seen here. Not a hard marker, but we usually see TB abscesses as yeah, slightly bigger in region, I mean in size, but again, not a very scientific differentiator.
Is hemorrhage uncommon in TB?
Yeah, it is uncommon, but it's not a hemorrhage per se. If you see the zoomed in image out here, it is more uniform along the outer rim. So it's usually due to, I think, the signal caused by the macrophages, which has high paramagnetic free radical production. And you see the inner rim is slightly hyperintense, which is more of a granulation tissue. So this is actually a paramagnetic abnormality caused by the macrophages rather than hemorrhage, because it is uniformly seen in all the lesions, whereas hemorrhage are usually more not as uniform as what we've seen over here. And the fungal hemorrhagic lesions are more central rather than peripheral. They usually project inside and not as circular or uniform as seen in these lesions. So
Dr. Nihaal, if I'm not mistaken, this kind of rings are usually seen in abscesses.
yeah, it is just a differentiator for abscesses versus other ring enhancing lesions, neoplasms. Yeah.
So last time we discussed that patient, remember which one we thought?
Yeah, Dr. Ved, your had more. Was not as uniform as this, more internal abnormality, hemorrhagic
because
lesions.
I stopped his anti-tubercular treatment and just continued on voriconazole.
So for fungal, which fungal can we think? Candidial infections, candidial abscesses are also typically smaller than this.
Yeah, Aspergillus and Candida are the ones with multifocal presentation,
but in Aspergillus, don't we see more of a vascular involvement and the disease tends to be very severe? And candidial usually are very smaller. I mean, what my understanding are, they can be very difficult to pick up even on the MRs.
yeah, they are more nodular. The Candida ones, they were more. The enhancement also is more nodular rather than ring enhancing. At least what we have seen.
I don't know, looking at the cells and the protein, the cells are
Yeah.
quite high, and the protein is also, I mean, not that high, but still TB does seem to be on the cards. I mean, it's very difficult to decide not to give not to give ATT in such a way.
I agree, Prabjot, and I am worried that the previous case we discussed last time also has TB still, because, and I think at that time you also mentioned the same TB and has the same finding actually.
So anything else to be tested, Dr. Vivek, Prabjot?
I don't think so. I think, I mean,
Well,
I'm
I think
sure
they have done a whole
you must
gamut.
be doing the same thing, giving
Yeah,
an
I think Dr. Abhishek is there. Yeah.
Yeah.
Yeah, actually, we have sent a pan-fungal antigen to PGI. We're just awaiting the reports. I'm not sure how much time to take. I mean, keeping in mind, initially, we thought as a TB started on ATT. But the only thing is he's received antibiotics for almost around 10-12 days. So we have seen a significant improvement in the inflammatory markers, like the cell count, the WBC count, CRP, and started improving. He clinically became much better after almost, I think, initially got 3-4 days antibiotics before he came in, then started on oral for 1-2 days, and then restarted IV antibiotics. So within 2 days of presentation, his symptoms were better, even the many of the signs reduced. So
but
then,
if the
I mean, the
child
second
is,
MRI.
yeah,
Yes.
if the child is getting better with antibiotics, then again, it is unlikely it is fungal. It might still be partially treated pyomeningitis.
Yeah,
Yes,
Prabjot, we are thinking of pyogenic,
yes.
after the follow-up scan.
Okay.
After the, yes.
Because given
absolutely.
the ventricular signal.
But the only thing is we don't have anything, even the PCR has come negative.
Yeah.
Bacterial panel, comprehensive bacterial panel has come negative. We have not got anything of the cultures. So even the fungal, we have got negative. Galactomannan is negative. Even the CSF aspergillus has come negative.
Oh.
So basically, I mean, we're just firing in the dark.
I think after listening through and seeing these images and previous my patients as well, what I'm now realizing that these ring lesion is like a host response, which is just for any form of infection, bacterial, viral, fungal. In the end, this MRI comes into most patients, and we cannot on the basis of these images tell this is tubercular, this is fungal. It's just the host response which just encapsulates whatever the lesion is into a small areas. That's what I feel, because you find these findings in many sort of pathologies now. That's what I feel that's what is happening. So when you look at it, you will say, oh, this is tubercular, but then you realize that the child has responded to something else. And it's like, and these are the follow-up images. In follow-up images, these ring lesions come up after the initial treatment. The initial MRIs are much worse in bacterial, in tubercular, in fungal. So maybe this is how the host responses and encapsulates and localizes the lesion, whatever it is, as the child is getting better.
So the second MRI, we see the surrounding edema is slightly worse compared to the first, and the wall of the lesions have become more thickened, more enhancing second MRI.
So is
The
it
second
again
MRI is
that
done after.
The host is responding, that the inflammation is trying to confine it? That's where the edema. In NCC, you also see it. When the NCC is dying, you develop edema. Not necessarily the child is worsening and has seizures. So you are having a situation where the child is clinically better, but the imaging shows few lesions showing more edema. So maybe the host is fighting.
Yeah, I agree, Dr. Ved. I think the edema is host response, and the capsule usually becomes thickened for the abscess, especially the pyogenic abscesses over a period of time. NCC, we couldn't find this colex over here, and on the T2 alpha, it's usually CSF signal.
No, this is not NCC.
Yeah,
no, I'm just giving an analogy.
Yeah. The only thing was the ventriculitis had improved on the follow-up scan within a week.
Yes.
Is there a possibility of brain biopsy? Should one go more often for brain biopsy?
Yes, sir. We counseled them twice for the brain biopsy, but then the parents actually, the child is having congenital heart disease. They didn't operate him yet, and he's been fine. He never had any major hospitals because of that. So they were very skeptical about going for biopsy. We told them that, if we don't have an answer, we are not sure what medicines to continue. So initially after one MRI, we gave them the option when most of the industries were negative. We told, fine, we'll wait for another week, repeat the MRI and then take a decision. Repeat MRI also, we had almost not major changes. We counseled them still. They said, sir, we still don't want to go for a biopsy. Then we said, fine, we'll wait for that pan-fungal antigen test sent to PGI. If that gives us anything, fine, or else we'll decide later on. And they went home like with the view of coming back after 1 week and then see. Yeah.
So you have got a Umaya for intraventricular. Are you giving that?
No, sir.
So IV antibiotic, right?
Yes, only IV antibiotics are going on. He's absolutely fine. Totally no meningeal signs, no headache.
How long will you give it? Just for my learning for future cases, like what is the plan? 6 weeks, 4 weeks? How will you decide? Because these lesions might take 6 months to disappear, even if the child is, this won't help. These MRIs won't help.
Yes, sir. So we're just waiting for that pan-fungal antigen. If that is also coming negative, then probably we'll take a decision as to either continue ETT and then stop antifungal, or just decide, sir. We're just waiting for that test.
You have stopped IV antibiotic?
No, IV antibiotics are going on, sir. Going on.
So that you will give for 4 to 6 weeks, right?
No, sir. We have not. Yes, sir. Yes, sir.
Right.
He's currently on the antifungal as well as antibacterial and EKD.
So antifungal, which one?
He's on lipo, and flucytosine.
Because voriconazole shouldn't be given with ATT because the levels can never be made with rifampicin. So voriconazole becomes 0. So that's the only. I don't know about M4 and fluconazole, but voriconazole doesn't work with ATT.
Initially started with ceftriaxone and vanco. 10 days of vanco was completed. We stopped, and only ceftriaxone is going on. And the ETT was started on day 3 of admission, sir.
These are always tough cases.
The good thing is child is responding to some medications. So. Okay, we'll get back to the pan-fungal reports for the next session if it's negative, and then maybe take a call as the next.
Sure.
And if the child is improving, then maybe it'll be helpful also. Okay, thanks, Dr. Abhishek.
Thank you. Yeah, thank you.
Thank you, everyone.
All right, last two cases from Pune. Krishna, if you're there, over to you.
Yes, sir. Thank you. So this is a 2-year, 10-month-old male child born out of non-consanguineous marriage, normal birth and development. There is a family history of simple febrile seizure, otherwise nothing relevant. He presented with new onset paroxysmal brief staggering episodes. It is lasting only for just less than a second, and there are no falls. This child was evaluated outside. EEG was done, which showed generalized burst of spikes and polyspike wave discharges, followed by background slowing for 1 to 2 seconds. Otherwise, the background was normal. And with this brief movement and this EEG, he was diagnosed as infantile spasms and put on 2.5 milligram per kg of prednisolone, tapering over 4 weeks, along with divalproex and clobazam. And with this, he had a dramatic response. He was getting these movements in clusters,
Just play
and
the
it
video.
completely disappeared.
Second video is post medication.
Both are before
Okay,
medication.
both are okay.
Yeah.
I think now he has a.
Yeah, video is with consent.
All right. So what do we
On
describe them as?
examination, on examination, it's a well child, no dysmorphism, head circumference is normal, bone, everything is normal. And post-steroid EEG was showing temporal spikes. He was also evaluated using an MRI, but it was not reported properly and came to us. So from the MRI, we reached a diagnosis.
Just for the radiology, radiologists out there, what do we term this as? He's just falls, or
He
Yeah, I would
doesn't
like
fall
the
because
panelists to comment like what kind of seizures are these, because they are
Yeah.
not fitting completely into atonic or even myoclonic seizures. So it's just taking 1 or 2 steps back and he sort of loses his balance.
he never fell.
Yeah, there are no eye movements or like he's responsive at that point. He just sort of stares, like tries to balance himself and goes 1 or 2 steps back in trying to balance himself. So what would
there's a comment for negative myoclonus versus atonic. Needs EEG from Sridhar. I think
yeah, but
negative
he's not
myoclonus.
fitting into very like classical atonic or classical negative myoclonus as well. So this was the video which was before the treatment, and so his EEG was also showing generalized discharges, but nobody has actually seen what is the EMG like during that point of time. And his EEG was like a CSWS kind of pattern, generalized discharges with mild attenuation between the discharges. And he was put on steroids outside itself. And currently the EEG is quite clean, except for few temporal discharges.
There's a comment for Deuce syndrome. It fits into that.
Deuce will also usually have
Myoclonus and atonic.
Yeah, mix of myoclonic as well as astatic kind of seizures.
No, but DOOs will not. So DOOs will not have electrical status sort of EEG. You know,
That's
so it
what.
will
So
have
the EEG is
polyspike
not
and
fitting.
spikes, and then you will have temporal theta, runs of temporal theta. And DOOs is very explosive sometimes. You won't have, you know, just child will fall, myoclonus falls, a lot of, and EEG won't be electrical status and sleep, if that's the EEG.
So EEG was just like CSWS only. Maybe next time we'll click a picture of
Because
that.
here it says
show it,
generalized
yeah.
spike, which is very different from ESC. It's not generalized spike polyspike, right? Because that will
They are
be more like
generalized.
DOOs.
They were generalized. No, but
That
it
is
was
more-
more like a CSWS. It is not like your generalized spike wave complexes. It was like CSWS, continuous generalized spikes, you know, coming one after the other with mild attenuation in between. That is not fitting in DOOs.
And on waking up, it will disappear.
No, they have not. It was only done in sleep, so that also part we don't know. All this was done outside, and he has come to us now after improvement. These seizures have already stopped, and currently, so we'll maybe come back to this after the discussion of MRI. Yeah.
Okay. MRI. I could not appreciate his structural abnormalities. No dysplasias, no malformations, no signal changes. The myelination is normal. Only the posterior fossa abnormality, which you can see in the cerebellar tonsils, at least in the axial images on the right side over there. You can see that there's some tonsil herniation, better demonstrated on lower panel. You can see on the coronal sequences, there is bilateral cerebellar tonsillar inferior ectopia. The title image gives us the best picture. You can see there is inferior tonsillar ectopia going on to the fecal sac on the cervical space over there. So I could not appreciate any structural abnormalities, only this TRE1 deformity with the bilateral cerebellar tonsillar inferior ectopia. Yeah, I think that was the only finding. I'm not sure if they cause
I
these
just
symptoms.
want to discuss with the other panelists as well. Is it looking like related or just an unrelated and incidental finding? Because we have had kids before who used to have like one child that we had was VP shunt malfunctioning intermittently, and that child used to just go into tonic posturing. Just suddenly he would be sitting and just suddenly he would drop with tonic posturing, and Actually, his MRI was showing a little bit enlarged ventricles, and he already had a shunt. So we did not initially suspect that there is a VP shunt dysfunction. And later on, during one of those episodes, we were able to catch the MRI again, and that was showing significant dilatation. So it was happening intermittently. So is a similar kind of process going on here?
So if
Or
there is a pressure, you should have polymorphic delta on the EEG. You won't have, electrical status spikes.
yeah. But
So that
have you
is,
noticed many a times when these hydrocephalus children are shunted, they develop CSWS pattern. I don't know what is the mechanism. And then I found a case report also on that.
Ma'am,
So-
almost, hydrocephalus can have associated electrical status in almost 30 to 40% cases. So it is one of the known causes of electrical status. The mechanism, I don't know, but it is a well-known association. Maybe that is why you're getting those discharges.
no,
In
but
this
we don't have
case-
hydrocephalus here, right?
Yes, sir. I agree.
Yeah.
In this case, it seems like it is not related. But sometimes in Chiari, we can see associated brain malformations. Maybe we are not picking it up, or MRI quality, I don't know, maybe Nihaal can say that there's some anomalies that we might have missed.
So just like that child, I was wondering whether there is intermittent hydrocephalus going on because the posterior fossa, you are having an obstruction there, the spinal cord, and this thing is also compressed. There's hardly
But
any
I think
space in the
Sridhar is right,
foramen
because we
magnum.
see it in, acute thalamic insult, perinatal asphyxia, baby's electrical status, and the hydrocephalus causes the thalamic compression, which causes probably those electrical status. It's the thalamus which is the culprit in those patients.
Agreed.
So, yeah.
So here
he-
is it like maybe the steroids have actually changed the picture. I don't know. Maybe there was more obstruction, and so I'm quite confused in this child how to go about. And are these two different conditions that he's having, or can it be explained by this?
I like to make a comment. In my experience and in my reading, at least 80% of Chiari 1 are incidental findings. Incidental findings. A Chiari 1 does not make a hydrocephalus for 1 second. Chiari 1, as a rule, does not make any ventricular dilatation. This child has no additional CNS anomalies, as far as I can see, and as far as Nihaal said. But you can also have secondary tonsillar ectopia, depending on the cause of your hydrocephalus, for example, in craniosynostosis. So I think in this situation, you can lean back regarding this finding and wait and see. You don't
Sure,
even, I mean, there is a controversy whether you should have a follow-up investigation. This controversial. I think you can at least wait for 1-2 years.
Sure. Thank you so much. That's very reassuring. Thank
Dr.
you.
Kavita, just on the side images, I think the child is 2 years or 2.5.
No, it's more than, I think, around
2
3
year,
years.
yeah, 2 year, 10 months.
Okay.
So
Just seeing the
Kavita,
picture.
every year we do get these patients, 2-3 patients a year who have these, when you do the EEG, you are just surprised and you have these events and they just respond so well to steroids and you will never get an answer and they will get better.
So I hope he's one of those only.
Yeah.
Yeah. Thank you.
All right. Yeah, thank you. Next case, Krishnapriya.
This is a 14-year-old male child, normal birth and development. From infancy, he is getting cyanotic spells. Echo was showing a top physiology with pulmonary atresia. And he was lost to follow-up and not operated and presented at 14 years with all the features of cyanotic cardiac disease. And he had a recent spell following which he had a GTCS, and that is how he reached us. MRI was done in view of encephalopathy post the seizure, and his hematocrit was very high. It was 70. So the MRI.
Okay.
He did not have any focal deficits.
Got it. There's just a punctate foci of restricted diffusion in the left anti-periventricular white matter out there. Other than that, I cannot appreciate other ischemic abnormalities. Nothing on the T2 sequences in terms of signal changes, some degree of volume loss. The marrow is slightly dark. If you see the Calvarian bones out there, it's slightly T2 hypointense. Mild hypertelorism, but intracranially, I cannot appreciate any other significant abnormalities. On the SAG image, what was the age? Okay, 14 years. Possibly there is some thinning of the cranium is slightly not rounded, slightly thinned out. Midbrain also is slightly thin, but maybe mild degree of inferior woman hyperplasia. But other than that, I cannot appreciate the significant intracranial abnormalities. So on the SWA sequences, there is some prominence of the medullary veins and the sulcal veins on both hemispheres. Also, you can see the cerebellar hemisphere has the folial veins, and also the subcortical cortical regions have these prominent SWA signal changes. So high hematocrit can cause venous stasis, and that venous stasis can cause increased extraction fraction, oxygen extraction fraction, which causes these SWA signal changes. And they can also cause the pathophysiology behind that is proposed was there increased platelet activation with releasing of the ADP molecules, and also there is oxidative stress, peroxidation, and thrombin generation. These are the primary findings for high hematocrit related disorders, and at least on this case, the SWA sequences have some degree of venous stasis in the bilateral hemispheres. But other than that, this small punctate foci, which possibly is a small vessel ischemic change. So yeah, these are the main findings which I thought were there in the scan. I'll open the case and for any comments and further questions from Dr. Kavita.
Yeah, the question here was, should we anticoagulate, because there was a venous stasis and one small infarct seen. His PCV when he came was, I think, 66 or something, and then after 2-3 phlebotomies, it has come down to 60. So, like we did start with Clexane because the first this thing reported one infarct. So, what would be the further strategy? Should we continue that? I mean, or we just manage with the of course, there probably the cardiac lesion is now not operable, or we just manage with the keeping the PCV low in the normal range. Comments from the panel.
All right. On the comment section, we have no need for anticoagulation from Cedar. The early operative intervention beauty shunt done. Dr. Vivek also agrees there's no need for anticoagulation. So I think status in terms of the medications given, Dr. Kavita.
Sorry?
They have mentioned that there is no need for anticoagulation. If shunting was done, the question was coagulation. Is that right, Dr. Kavita? Anticoagulation?
Yeah. Because he has polycythemia, which is like not going to recover so fast, and he is at risk for getting, and the MRI is showing still. So the cardiologist has said it is not possible to operate him due to whatever reasons. And so this child is also having some venous stasis. We have already done 3 cycles of phlebotomy for him, and mostly, they're not very good in follow-up also. So we were wondering, like, whether we should put them on. I mean, we have already put him on anticoagulation when he was in the PICU. So we wanted the group's opinion, like, is it okay to continue that, or is there any rationale in continuing that? Because is it going to help? I'm not sure.
So Sridhar and Dr. Ek agree that there is no further need for anticoagulation.
No, the thing is, that is the ideal world, because if he cannot get it done, then so 2 years back I had a boy who had severe headache and he had cyanotic heart disease, and his PCV was 70%, and we did a CSF pressure which was really high. So he's a benign intracranial hypertension, and he has venous thrombus. Venous thrombus due to polycythemia leading to BIH. So if somebody is not agreeing, then the logic should be, I haven't encountered this, as Kavita is saying, that one should then give Clexane. If somebody is not going to get BT shunt and somebody is not going to follow properly, then his PCV is going to go up. Like I haven't experienced it, but logically then one should give it, because a similar case I had was like a CVT presenting with BIH, a cyanotic heart disease child. So he's going to have CVT and BIH now in future if he's not going to be not going to get these things done. So that's the worry, right, Kavita?
Yeah, agree.
Yeah. So one needs to search the literature, but logically speaking, if somebody is not going to get the palliative surgery done, he's going to have his hemoglobin high. Why not give him Clexane? Will it harm him?
So that's what is the question. I mean, we can even change to oral this thing, rivaroxaban or something. But the thing is, like he did have a small impact also. So that is all related to the stasis.
Yeah, so he's having CVT, right?
Yeah,
Some sort of CVT.
Yeah.
So CVT treatment is Clexane. Like not treatment, sorry, to prevent.
Prophylaxis. So any other differing opinions? So, because I was in two minds what to do, I thought I'd just take the opinion of everyone here. Dr. Eugen is there?
I feel not sure about this situation.
Okay.
Your logic is there, Kavita, but probably literature search to, you know.
Yeah, we did that during CSVT when we wrote that. Like they are not so specifically written anywhere, like in congenital heart disease with high PCV. Especially if there is an impact, I would tilt to
Because
giving
it must
rather
be from
than not.
Western literature, from where the things are done very quickly, not from our countries where we have these, parents not agreeing, BT shunt cannot be done.
I know.
Not being followed up properly.
Yeah.
Yeah.
No, there is no venous sinus thrombosis, Kalpana ma'am. Only thing is that there is a stasis and there is a risk of getting. So those Dr. Nihaal, if you can show those images.
My question was, do we wait for a CSVT and infarct and then start meds, or the preventive is better?
Yeah,
because he already got that small impact. That's why then we, of course, tilted towards starting ki baad mein dekhenge, we'll think over and then decide whether to discontinue. So
stasis is there, generalized stasis is there, but there is no thrombosis per se. CSVT.
Yeah.
At least we don't have venogram, but at least on T2s and T1s, they did not appreciate any thrombosis. The flowers were patent. Yeah, the only question was the dilemma is, we wait for infarct, CSVT, and then start, or prevent it? And how long do we prevent it? How long can the medications be given?
Yeah, that's another question. Because we already started it. Now, how long to give? And what I'll maybe try that at least they come for phlebotomy regularly. And if that is not possible, then maybe put
So are not heart disease patient already on oral anticoagulation often?
No. They've come for the first time.
Okay. For their heart cause, cardiac cause, sometimes they're on oral warfarin already.
Yeah, but not yet given anything. And the cardiac surgeon is saying that he's got multiple MAPCA, so there's no need for surgery. He doesn't want to do the surgery. Okay, thank you so much.
Okay.
Yeah.
All right.
Thank you very much.
Thank you, Dr. Veda. And yeah, I think that's our last case. So yeah. So we'll meet again in 2 weeks' time. You can submit your cases by the 13th of December. You can email me or message on the WhatsApp group. So till 2 weeks' time, 15 December. We'll see you then. Thank you again for the case presenters, the attendees, and the panelists who have joined in. And see you shortly.